We're ready.
Very good. Thanks, John. Hi, everybody. I'm delighted to be back with Best Notes and providing some continuing education for their user network. And I am an addiction psychiatrist, as John may have said in this recorded portion of the program. I chose this title because of how people think this is just like so vexing and almost an unsolvable issue, and that's just so inappropriate. And I want to provide you some answers to the problem today. So this is a treatable condition, and we're going to talk about how to do that. So now there's no doubt that this is a dangerous drug. Move this little thing, just may get rid of it. There we go. I'm going to put that up there. So there's no doubt that methamphetamine is a dangerous drug. What it does is it enhances glutamate circuits, amping up almost all other neurotransmitter circuits because glutamate modulates all neurotransmitter circuitry. So it turns everything up. It certainly works on dopamine and norepinephrine, but it just hypes you up. And it does it on a very basic chemical level at the central level of the brain. But what's dangerous about this drug is that when you turn everything up, you just turn all the knobs up, you can end up with extra sensations like hallucinations and extra thoughts like delusions and hyperactive motor activity and rapid speech, and just not only all that, but you truly can burn up the brain by having overactivity of the nerve cells, and it causes intracellular damage, and eventually you can get brain shrinkage and things like that. This is the old frying pan public service announcement from 25 years ago. This is your brain on drugs. So the first wave of meth in the U.S., most available meth was made in small batches in bathtubs and home labs and things like that. And these noradrenergic molecules, ephedrine and pseudoephedrine, were available as over-the-counter decongestants until they got put behind the counter. And so people would, make homemade methamphetamine. It would be low potency, low purity. And so, you can squeeze the balloon, but it's going to go up on the other side. So we got rid of the bathtub stuff, and we ended up with much more potent real lab stuff. So so the first wave we took care of by drug control, but now we're getting purer, more potent stuff from Mexico. And it's not made from ephedrine, it's made from P2P. And so, just like when we shut down on prescription opioids, heroin went up and then fentanyl has exploded, we got rid of the bathtub meth and we ended up getting much more intense stuff. So the Rockefeller Institute has talked about, this first wave, second wave. That's where I got those slides. So, and so I said this. So what does it actually do? Again, it produces hyperactivity in every way of thinking, of speech, of behavior. And there's a decreased need for sleep. Somebody can look acutely manic. That's the differential diagnosis. This is really unfortunate that you can end up with cognitive impairments from burning up your brain, but you can end up not only with acute hallucinosis and delusions from an intoxication spell, but you can end up with persistent psychotic symptoms. And when I began to practice in Madison, Wisconsin in 1989, there were stories of the state hospital back ward having people from the early 1970s wave of amphetamine still burnt out on the wards, not able to be discharged, chronically, persistently mentally ill with stimulant-induced psychosis. In the emergency departments where I practice now, It's incredibly prevalent, and the psych wards are at least half amphetamine psychoses. It's just phenomenal how prevalent this is. But the problem is when it gets to be persistent, and you can definitely be psychotic for life, actually. Um, so it does produce a lot of fear, but it reminds me of other eras in my 40 years of practice of, there's something new and people say it's not treatable. Well, I want to help you understand today that this one is treatable. There's nothing magical. It's still addiction. And the way you treat methamphetamine addiction is you treat addiction. Okay, that may sound simple, but, breathe. Just calm yourself and realize you already have the skills. And just do what you usually do. And again, as professionals, there can be psychosocial therapies that you know how to do. There's pharmacological therapies. Many of you have prescribing privileges, or some of you do. And then you don't forget the third leg of the stool, recovery support activities, which generally are peer-to-peer with nobody but peers. And this is, AA, NA, Cocaine Anonymous, Meth Anonymous. It's the 12-step meetings. It's Smart Recovery. It's Celebrate Recovery. But also it's working with a peer coach, somebody with lived experience, but who may have some training and some certification, and is sort of invoked, and they may work for a treatment entity, and they're actually salaried people and what have you. So recovery support activities generally are only peer offered and led, but we now have recovery support specialists who can be of help. So all three. So we're going to talk about psychosocial therapies and pharmacological therapies. And so these are the two big psychosocial treatments that are evidence-based treatments, the matrix model and contingency management. Now the matrix model, Rick Rawson put this together 50 years ago with, again, trying to deal with that first epidemic where people said, we don't know what to do. Well, he said, try this. He gave it a name. I don't know how much he's profited from it himself, if he patented it or what have you, but it is open source. It's really an evidence-based practice of SAMHSA, and CSAT promotes matrix model, and CSAT has its own treatment manuals that were used in research of the matrix model. Now, the matrix model sounds like the name of a movie or something else that's like high-tech and unique. The only thing unique about the matrix model is how beautifully it integrates everything into eclectic therapy. It's the things we already do, but it puts it into a manualized packet with a treatment guide for the patient, worksheets for them to fill out, a lot of behavioral treatment, but using all the principles of cognitive behavioral therapy, motivation enhancement therapy, 12-step facilitation treatment, contingency management, dialectic behavior therapy, family therapy, and even pharmacotherapy. All of them are wrapped in the matrix model. The matrix model is everything we know all wrapped into one. And it's just great addiction treatment. Is the matrix model appropriate for other addiction besides stimulants? Of course, it's just good quality, eclectic addiction treatment that you could offer to anyone at any time. And there's an evidence base that when you throw intensity and duration at these folks, when you throw intensity and duration at these patients, they can get better. So the other is contingency management, which we're going to drill down on if we have time. John and I talked about maybe making this a two-part thing because I have so many slides, but we'll see if we can get it done in one. And I have a lot of detail on how to do contingency management. But okay, now again, manualized treatment. If you're not familiar with manualized treatment, to do clinical trials in ways that will get you funding from NIMH, NIDA, or NIAAA, you have to have the treatment be very explicitly described and delivered the same to every patient in the study, or it's not legitimate research. So they put the how-to into a treatment manual. And there's a treatment manual for CBT, there's a treatment manual for MET, a treatment manual for TSF, and those were the three treatments that were studied quite a bit around 25 years ago at the level of NIAAA and NIDA. The matrix model got its own manual, and it's open source, free of charge. There, here's the title of it. Rick Rawson was part of the group that put together the manual for the feds, and it's paid for by tax dollars, so you can get it for free. If you don't want to, you can spend $1,500 and get the same thing through Hazelden Press, but it's a lot glitzier. It's got DVDs, it's got video examples, it's got, I may have some lectures that are already recorded. It's got, it's a real teaching thing. It's really excellent. So I'm not going to say anything bad about it, but if you don't need all that, and you can just self-teach yourself by using the manual, which I think most professional clinicians can do, you can just download it yourself. Now, I just want to give you a sense of what's in it. There's early recovery skills group, there's relapse prevention group. It is a time-limited model. I forget the total number of weeks in the matrix model. It's probably 12, but it might be 20, might be 24. And again, a 24-week clinical trial is very expensive to run, but it's more realistic. It's closer to the real world because nobody, well, they do. We still have this terrible problem of people trying to do 30 days of treatment for a 30-year disease. And that's just ridiculous. And you need to do at least 90 days of treatment, but ideally 2 years of treatment. And we know that the most effective treatment is the treatment that physicians under monitoring get, and they have 5 years of treatment. So, if you keep the treatment condition in place for enough duration, you can get some results. Early recovery skills group, a fixed 8-session program with handouts for each one of these sessions. Again, CBT methods, identifying your triggers, external and internal. There's education on 12-step programs. There's some stuff on neurobiology and neurochemistry. Obviously, thinking, feeling, doing is classic CBT. So these are the first 8 sessions, and then they have, oh my God, how many relapse preventions? So many examples. And actually, it's like a Chinese menu. You kind of pick what you want to do that week based on where your group is at. So this is a drill down on the stop the cycle. You got to just stop. And so it teaches people, again, the CBT methods of what are the thoughts or events, the people, places, and things. Then they shoot your cravings up. How do you deal with cravings? How do you ride the wave? How do you distract yourself? So all of this is in there, including scheduling time and the whole check-in method. The matrix model manual is very behavioral in that it does have people fill out their own worksheets, and daily check-ins is a really important thing. And what are you doing with your time? Tell me behaviorally what you're doing. And it's all about productive daily activity and structure. These handouts are great. So again, thought stopping techniques when you have irrational thoughts that intrude and would tend to lead you down a path of negative emotion and then unhelpful behavior. Obviously, the whole thing with craving, you want to break the chain. You don't make the behavior of drug use automatic in response to certain thoughts or feelings. There's classic CBT stuff. Okay. So again, the importance of scheduling, some education about triggers. Then you ask the patients to identify their own triggers, and you have group discussion, and everybody's to do their own triggers, and their assignment is your own list of internal, external triggers. And so it's structured. I mean, it's highly structured. Some people don't like that, but it's very efficient. It's very efficient. And I would encourage you to give it a try. So here's the relapse prevention groups. This is 12 different topics. There's 24 topics. There's 32 topics. Now, if you're doing 2 sessions a week or 3 sessions a week, you can get this thing done in 12 weeks. So if you're using this as an IOP format 3 days a week, that's 36 sessions. Well, we ran over a little bit, didn't we? Because we had 8 of the intro. But you don't have to do all of them. You could leave some out and maybe pack it into 36 sessions. And again, there's handouts for all of these things. It's just a great document, and I'm a big believer in this. Okay. They also have handouts for couple sessions. They have handouts for uh, uh, doing groups that just talk about social support. There's handouts on how to build drug testing into a matrix model treatment program, and how you work with patients, clients, when they do come back positive. And of course, no one should take any action based on an unconfirmed urine drug test. So that was the matrix model. We got there to that pretty quickly. Now, contingency management is really interesting. I think it's interesting. Excuse me. It is classic operant conditioning. It's rewards, it's negative reinforcement, which is not something, do something that gives you reward. It's do something that takes away pain. Punishment is you do something negative to somebody for doing something you don't want them to do. Positive reinforcement is you get a reward for something you do want them to do. And negative reinforcement is you give them something to relieve their pain, which makes it more likely that they'll do the behavior again. All these basic behavioral principles of operant conditioning are woven into contingency management. And so what is the contingency? Contingency means you'll get your prize if you do the right thing, and you won't get your prize if you don't do the right thing. So the outcome you get is contingent upon what you do. Simple enough. So you will increase the frequency of the occurrence of a behavior if you reward it. But the reinforcement must be immediate. It must be tangible. The desired behavior must be objectively measurable. And so in preparing for this, I did a lot of reading on CM. And the way CM fails is what you're asking for, what your targeted behavior is that you're measuring, must be objective and discrete. And it's not debatable whether or not it happened. There's no question about whether it happened. And then you're trying to increase the frequency of that behavior that you can measure. If the contingency, positive or negative, doesn't happen quickly enough, you lose all power. And again, the reward must be unambiguous, unwavering. It's very clear what you're going to get. It must be clear up front what you're going to get. And not following strict behavior therapy principles lead this to fail if you get loosey-goosey on any of it. The behavior, the reward, and the timing are just absolutely critical to this treatment. Now, you may not know this, but there is no psychosocial treatment in addiction that has better results than CM. None. Nothing works better than CM. The big question is, then why isn't it done more often? Well, you got to plan it out. And this whole idea of paying people for doing the right thing doesn't set well with some people. They think it's weird. But if you want outcomes, this gets the best outcomes. It can be used with any substance, but it's interesting. You design a CM program for abstinence around one substance, and that's all you can do. If you try to have the behavior be abstinence from two different things, it loses power. So are they going to be off using other drugs? They might be, but this targets what you're trying to target, and it's often stimulants or THC, but you can't do two at once. So it's useful for all sorts of things. I've been reading articles lately on using CM for weight loss in adults and adolescents. So you can do it for behavior change. You can do it for exercise versus sedentary behavior. You can do it for, you can design this for all sorts of things. It's not just in addiction. It can be done by non-doctoral or even non-master's level staff with short duration time. So it's affordable to do it from a human resource standpoint. You don't have to have your highest trained people doing it. But the dilemma is how to do this in community settings, because the research that shows this is the most effective treatment, it's research. It's not real world. It's clinical trials with a very high degree of structure. How do you do this in community settings? So now, the biggest training manual is written by the Department of Veterans Affairs, Veterans Health Administration. Now, I work for the VA, and they say you can do outside work like working for Best Notes, but don't tell them you work for the VA, and don't say you're representing the VA. In this presentation, I am not representing the VA. I'm just sharing with you what's in the training manual, because there is no better example than what the VA has done for implementation. I believe that it's used somewhat at the VA where I am, but it's not done according to Hoyle, because we don't have point of care drug testing set up, and that's keeping us from doing a full implementation. You'll understand what I just said as we move along. So it's an evidence-based behavioral treatment that gives financial rewards to maintain abstinence. So that the longer term rewards from abstinence have a chance to catch up. This is what the training manual says. Using behavioral principles and of positive reinforcement, extinction, punishment, and negative reinforcement. So negative reinforcement is something that will take away pain. Extinction is when you stop reinforcing something, the behavior stops happening because it's no longer rewarded. So you'll see how these programs are designed as we go through this. So again, you pair a very discrete behavior with a very discrete contingency. Reward is more effective than punishment, but punishment does work in addiction treatment, in contingency management, when you're doing it according to Hoyle. Now, drug courts and professional health programs are the biggest example of contingency management principles being applied. Again, if you were taking a college course or a graduate course in addiction treatment, you would learn that the most effective treatments, the best outcomes happen in professional health programs or in therapeutic courts, drug courts, OWI courts, veterans courts. And again, it's because it's very, very, very tightly designed with targeted behavior and very undesirable contingencies if you do certain things, like if you don't show up for sessions or if you lie to the therapist about whether or not you're using. You can get a night in lockup if you're in a drug court. And of course, the biggest contingency in drug courts is if you fail drug court or are considered to be discharged from drug court unsuccessfully, you revert back to criminal court where you've already pled guilty to your crime. But professional health programs, again, with physicians, are 5 years of monitoring. The average duration is actually 7 years because a lot of people voluntarily stay in monitoring. They want to stay in monitoring. But the basic principles of reward can actually drill down to something really simple. I mean, there's research done on this. There's truly research done on this. If you have a bowl of candies or a bowl of chocolates, either next to the chair where the patient's sitting or at the desk where they make their revisits when they go back out to see the reception staff, that increases a return visit rate. I mean, we think we're sophisticated, but we're damn primates. We're just sophisticated primates, but we work by the same principles. You reward us, we'll do it again. It's just like training your pet dog to do the rollover trick. You give the reward, and again, the behavior has to be very discrete, and the reward has to be discrete and has to be given immediately. And you can apply this to Homo sapiens, and it works very well. Okay, so for clinical implementation, you have to design the whole thing with a budget. Why do you need a budget? We not only have to do a pro forma with number of visits, fees per visit, HR, utilization, what your salaries are for the staff, but you have to have the cost of the rewards. And most places go, there's no budget line for that. What do you mean? But if you want results, you do it. And the VA does it because they got a closed population. A big system like Kaiser could do it because they're at risk. They're at risk. So again, what's the behavior? Totally understandable to the patient. What are the contingencies, and what's the payoff? And how does the payoff work? The payoff works that for one negative urine, you're given a certain level of reward for a series of negative urine. So after you reach a threshold, the reward goes up. So you have to keep juicing the reward to get Homo sapiens to keep doing the same behavior. If you want the behavior to persist, you have to make it worthwhile. So you got to raise the ante. The big negative thing about this, the punishment is if you fail one step, you go back to go. And all of the higher level rewards thresholds you were at are wiped out and you go back to start. I'm going to explain this a little bit more as we go on. So again, the VA system over a decade ago got involved with this because of a very famous memo that went around saying, if this is the most effective treatment according to the research, why do only 1% of veterans get this modality? And the same thing could be asked in a different article, was asked, why in the community, why aren't people demanding this? Because it's more effective. Why don't more patients outside the VA have access? And one author wrote, it's going to take pressure from patients and family members and from advocates because, why doesn't your agency do this? In a meta-analysis of 7 studies at 1-year follow-up, it says these data suggest that policymakers should support and cover the costs of CM because the results at 1-year follow-up are better than CBT, TSF, or a regular treatment as usual IOP. This works. Immediate financial reward for initiating and maintaining abstinence. If you don't maintain it, you go back to go. It really helps with engagement. I worked in a drug court for a year. It was one of the most enjoyable experiences of my whole career. It was so different and it was so positive. It was all cheerleading. These judges have to be trained, and the best drug court judges are showmen and showwomen. They're on stage and they're just cheerleading, and they applaud positive behavior. They reward. They ask for applause for the drug court participant for success, and they make it into a show, and it's like a game show. And we'll talk about the fishbowl and how the fishbowl is like the central thing of CM programs. I loved this slide because it explains addiction in a somewhat different way. I talk about salience and how our amygdala does a reshuffling. So we have a motivational hierarchy change. So the things we're motivated to do are use our drug as opposed to doing other things that used to be rewarding to us. And other things like going to the kids' soccer game or listening to a CD of music fall by the wayside because the drug becomes the salient thing, the front row center behavior for the individual. So this says there's an increasing value of the decision to use a drug and a diminished value for other rewards, like taking a walk, looking at a sunset. Individuals with addiction engage in delayed discounting. So what that means is that they have greater preference for immediate versus delayed rewards. If you give them a chance at a big payoff later, they will instead go for immediate payoffs, even if they're smaller. There have been all sorts of research programs done. The gambling game, there's a card sorting thing. If people go for immediacy, they don't go for the tortoise wins the race in addiction. That's their general psychology. So a stronger preference for immediate rewards and something like, well, it'll help your career. Yeah, what's my career? You gave me a line of cocaine right here. I know what that feels like. The more the reward is delayed, the less it is valued. So in contingency management, you try to provide an immediate reward that can compete. Over time in addiction, the reward-related brain areas start to respond less to non-drug rewards. The lowered responsiveness further discourages the pursuit of non-drug rewards. So the good news is that when you stop the behavior, the brain does heal, and you get some normal functioning back. So CM improves treatment prevention. Again, the most important outcome for any session with any patient with addiction is that there will be another session. You can't help people if they don't come back. So you want them to come back. So this improves retention by rewarding them for being there. It extends the duration of abstinence. And then you end up with other outcomes that can have the chance to appear when you've established long-term abstinence. Allows people to benefit from other treatment components and nationally occurring. So the VA had this big project that rewards average $200 per patient over a 12-week period of treatment. And again, it requires you measure abstinence by drug testing, and it works best for stimulants because they're rapid excretion, and it's hard to do this with THC because a positive urine for THC may not mean they've used recently because it can linger. So using the drug testing method to confirm that they've done the behavior you want, which is abstinence, is harder with THC. Can be done, but it's harder. The VA's approach was to integrate CM into treatment as usual, though I saw a study just this month that shows that adding other modalities to CM doesn't really enhance the intrinsic benefits of CM. So what do? You select the rewards or prizes. They must be meaningful. And then there's the fishbowl. So there's 500 slips in the fishbowl, 250 say good job, which means, yo, good job, great. 209 say small, so that's a $1 value, 40 say large, and one says jumbo. Now, many VA programs use 3 jumbo prizes in the fishbowl. And again, what happens is early on, you're given 1 draw in the fishbowl for 1 day of abstinence. Later, 1 day of abstinence will get you 3 draws. Later, it'll get you 7 draws, you see? So over time, we're going to really increase your reward and give you 7 chances at this fishbowl to grab whatever you're going to get. Cash rewards are not a good idea because people can use cash for alcohol and drugs. Drug courts use vouchers donated by the community businesses, car washes, pizza shops. In the VA, there's the canteen, which is a store. It's like a PX in the VA hospital. And you can buy, it's like a general store, everything from soup to nuts. And so they get vouchers for the canteen, which can be used through the cafe side of it or the durable goods side of it. And so they have value. So you're getting a voucher. So it's like getting a gift card. So you're getting a voucher for $1 there's a $5 voucher in some of these. It's 20s and hundreds. You can structure it in different ways. But if you're going to do this in your agency, you have to have administration totally behind it. Everybody has to know exactly what's going on. You have to do it very, very by the book, and you have to budget the rewards. But again, it's $200 per client. If you're treating 100 people, the numbers are getting up there, but it gives results. And if you are getting a contract, which is a performance-based contract, you're going to get better results and maybe, do better with the person that's giving you this grant. In the fee-for-service clinical practice world, it's very odd. And basically, place such as just stick their neck out and say, we're going to invest in this because we want better results. So this article says we now have an example of a large-scale successful implementation through the VA. There's been articles written on this implementation, what the training involved, rolling it out, and what the results were. Okay. The dilemma of effective intervention with a wide range of applicability and it will be difficult to resolve without payer and policy changes. Everybody's got to get on board and you have to figure out a way to pay for it. It might work better in a not-for-profit working off contracts. Just a for-profit clinic getting fee-for-service, it's a weird deal. But I've got some articles here for you. Here's one. Okay. And then I've got other articles. I can get them to John, the titles that I drew this from. Again, you've got the fishbowl. In the drug court I worked in, you didn't get multiple draws. It was interesting that they didn't do that. I don't know why. And again, it was for things like car washes or pizzas or Walmart certificates or tickets to the county fair or what have you. Urine collection doesn't have to be observed, but it should be immediate results. And that's the thing. You need a point of care testing or a lab that'll give you immediate results. Award draws if the test result is negative for the target drug. Record the draw results and the amount of coupons dispersed. All price slips are put back in the bowl, so everybody's odds stay the same. This is an example of the first session. So we're going to move on because we're getting close to time and we're going to talk about pharmacotherapies. But, you know, there's things that you can drill down on your own when you get the slides. Current abstinence is not an exclusion criterion to starting. People are encouraged in the veterans program to do other treatment, not just to do CM. The drug testing is more discreet in for stimulants. Again, frequency of sessions, twice or 3 times weekly. You can do other kinds of treatments along with it. And you have to worry a little bit about false positives on your drug tests, and you should get confirmatories. And if somebody gets busted back to 0 for a positive that on confirmatory comes back negative, you should restore their status. So they're back to the point of like getting 5 draws on the fishbowl instead of 1. It works. 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 It's the most effective of anything that's been studied. So it's brief. It's low cost overall, combined with anything else. In the VA, it's endorsed. It is fun. Again, you know, when people win things, there's a big celebration. It's just an incredible positive thing. It's also can be done on digital apps, and I've got some stuff here on Dynamic here, which is a private company operated by a friend of mine that's got great results, all sorts of articles and literature proving that it works. Again, we just talked about psychosocial matrix and CM. You never forget the recovery supports. It can be recovery coaches. It can be Celebrate Recovery for non-denominational Christian folks. It can be Smart Recovery, which is facilitated, even though it's a peer support program. So you never forget that. What's about the pharmacotherapy? The bugaboo is that there's no FDA-approved medication. So do we throw our hands in the sky and go, I can't help you? Well, ASAM and AAAP, the 2 big professional societies, the American Academy of Addiction Psychiatry, American Society of Addiction Medicine, said this is nonsense. There's so many articles in literature. We know things that work. Why do we keep saying there's no proven treatment just because there's no FDA-approved drug? Because nobody's submitted an application to the FDA for an indication for stimulant use disorder. But they published a practice guideline, which is on the ASAM website for free. AAAP, I'm sure, has a link as well, but I just know the ASAM one's right here. Here's the link. I can walk you through how to find it if somebody needs it. But it's on the ASAM website. And it says that adolescents and young adults should be provided the same treatment anybody else is. So The pharmacotherapies are bupropion and topiramate. Bupropion is the thing that's used mostly. It repletes dopamine after dopamine depletion from cocaine or methamphetamine use. Bupropion is the number one drug to use, and you dose it pretty much like you do for major depression. Topiramate has the negative effect of cognitive impairment in up to half of patients, but otherwise it's well tolerated. So this practice guideline goes through the evidence for all sorts of things, including baclofen and valproate and other things, mirtazapine. So the guideline says the first clinical priority is to get your diagnosis right and to deal with acute psychiatric symptoms. And the biggest problem with stimulants is not that you can slow yourself to death and withdrawal, but people on the immediate come down can get suicidal. And this is probably neurochemically driven by the acute dopamine depletion. So somebody in a speed crash needs to be assessed for suicide. And if you don't, you're liable and you have no leg to stand on, because literature is so clear that suicide does happen during the crash off of stimulants. So you ask people about suicidality and manage it as you need to, including sometimes with hospitalization. Address biomedical things up front, and deal with things like wounds and infections from injection sites and xylazine wounds and what have you. So deal with the urgent things first. Do a full biopsychosocial assessment. Make a good differential diagnosis, and realize that a lot of the psychiatric symptoms are going to be substance induced. But do your assessment, and if it's an enduring thing, especially that happened before they ever used drugs or happened during long periods of abstinence, it may be an independent psychiatric condition, but until proven otherwise, psychiatric symptoms are going to be substance induced in this population. You do have an elevated degree of suspicion for heart problems and muscle breakdown, rhabdomyolysis from, again, just overactivity and just so many signals from the brain to your skeletal muscles to move. And people, walk or run, and they over-exercise, and they can break down their skeletal muscles, and the actin and myosin break down, and you end up with rhabdomyolysis because the protein that makes up muscles clogs up your glomeruli in your kidneys, and you have kidney failure. So, this is a population that does have medical complications and has psychiatric complications. So evaluate those, and then consider the behavioral treatments. CBT and matrix model, and then community reinforcement approach is another CBT spinoff developed at the University of Mexico by Bob Myers and a colleague. I can't remember the colleague's name. So CM, if you can implement it, is the most important because it got the best data, but there are other psychosocial treatments that work: CRA, general CBT, and matrix model. Even the ASAM practice guideline talks about the technology-based things, the app-based therapies, the digital therapies. You should consider those for people who have trouble accessing in-person care. For cocaine use disorder, bupropion is number one, topiramate's number two. I like baclofen, even though this committee didn't like it as much as I do. Doesn't work for everybody. Works for some to take away cravings. Gabapentin and Depakote have been, and Tegretol have been tried. Again, the expert panels that worked on this practice guideline didn't find that those are biggies. Other antidepressants such as Prozac, some evidence, but not as strong. Bupropion is clearly the gold standard for pharmacotherapy for stimulant use disorder. There is a big study that was done on combining bupropion and naltrexone. I don't really understand the rationale, but it clearly works. I'm finding that the psych residents that I work with know about these studies. They're being taught about in residency programs. And so this is bupropion combined with naltrexone. But in the practice guideline, these slides are directly from the practice guideline, just cut and paste. It says, obviously, if somebody's using alcohol, you want to think about naltrexone. If they're using tobacco, you want to think about bupropion, Zyban. And if they have depression, you want to think about bupropion. But you don't need those comorbidities. If they have stimulant disorder, think of bupropion. That's the drug of choice. So amphetamine type stimulants as opposed to cocaine, topiramate, you would give additional considerations if they have a bipolar history. Mirtazapine could be considered if they're having trouble sleeping or if they have mood disorder. So Remeron it's got data. It's low certainty, it says. It's a conditional recommendation. But again, some guidance for the whole treatment community, some guidance instead of saying there's no FDA-approved drugs, there's nothing you can do. Don't feel like there's nothing you can do. I do talk with patients about baclofen. That's just me. I like the articles, and I've had some people say, oh my God, it took my cravings away completely. But it's not reproducible enough. It's not generalizable enough. But bupropion for all of them. If they have a history of seizure disorder, other than just if it's stimulant-induced seizures, don't worry about that because they're not using stimulants. But if it's like a big TBI or a stroke, and they have epilepsy, then you're in trouble because bupropion lowers the seizure threshold, and you really shouldn't be using it. So that would be very unfortunate. Then you have to use the alternatives and try your Topamax, which is invented as an anticonvulsant.
Dr. Miller,
we're about done. Maybe we take a couple of questions through the chat. We're almost done here with the formal presentation. The guideline, again, you can read the guideline on your own. I just cut and pasted things. Be aware of co-occurring disorders. There's a high rate of quote unquote dual diagnosis in the stimulant use disorder population. So treat the other conditions as well. And see, we are done. So let's go to the chat and take a couple of questions.
That's great. Thank you, Dr. Miller. Aaron has a great question. What is the treatment for those that have a ADHD diagnosis? Is there a formulary standard she could follow?
Well, this is discussed very, very well. Let me see, stop here. This is discussed very, very well in the guideline that I pointed out. Okay. You should use psychostimulants. For anybody with addiction, I try to use Vyvanse because it's truly long acting. It's a slow release. It's, again, anything that's a short half-life, quick onset, so very lipophilic, gets to the brain quickly, crosses the blood-brain barrier fast. Anything that gets there fast and leaves fast is more quote unquote addictive. And so Vyvanse is my drug of choice for all people with addiction. And in this population, obviously, stimulant addiction and ADHD, I'm gonna go for Vyvanse, though they talk about Adderall in the guideline. It's actually been the case for most of my 40-year career that treating co-occurring ADHD, even with stimulants, gives better results for addiction than if you didn't treat it. So people have been afraid of using psychostimulants to treat ADHD forever, but there's been evidence to support it forever. I mean, for my entire 41-year career. Would you try non-stimulants for ADHD? You might, and you know what those are. Your alpha agonists, so your clonidines, your guanfacines, all that stuff. Strattera, of course. Would you try those? But they're going to treat the co-occurring ADHD. A stimulant would treat them both. It would, and so this big expert committee of ASAM and AAAP says if you've got somebody that's got ADHD and stimulant use disorder, go ahead and treat them with stimulants, and that's okay. And licensing boards aren't going to cause you trouble because there's so much professional support for it. Now, the problem is diagnosis. PTSD can look like depression, can look like anxiety, can look like dissociative disorder, can look like ADHD. People with really difficult upbringings can look like they have ADHD. They have no predictability, have no structure, and they can look scattered. That are
Looks like we're having a little technical difficulties. Oh,
well, I shouldn't
there
have
you
been
are.
timed out. I shouldn't have
Yep,
been timed out.
yep, you're
Uh,
back.
okay. So, so there we go. Um, yeah, get your diagnosis straight. That's always the first thing in treating anything. But uh, one of my all-time favorite articles was one that looked at kids who go to campus health asking for stimulants for ADHD to improve their academic performance in college. Those kids were found to have very high rates of cannabis use disorder, that their problem with attention and focus and memory and good grades came from the fact that they're using way too much THC. And they love to say they have ADHD, but do they really? And so I treat ADHD. I'm an addiction doc, and I treat ADHD, and I use stimulants. But I really, really, really try to be careful with my diagnosis and use it only when I'm really sure of what I'm dealing with, and it's not confounded by something else. Um, so yeah, this whole thing about the fishbowl, I just found it so fascinating. In drug court, um, you don't always get a trip to the fishbowl. You have to be doing what the therapist wants you to do to earn a trip to the fishbowl. Um, and as I said, they didn't increase the number of draws. So it's not like when you're in phase 3 of drug court, you get to do 3 draws instead of 1. But I think the fishbowl in drug court was all rewards. There were no slips that said "good job" that I can remember. Or just have a nice day, or some platitude to make people feel happy, because they're not happy. They didn't get a damn prize. They're unhappy. So you know, but so in drug court, I think everything was a prize. If you got to the fishbowl, you're going to get something, though it might be very low value. So I hope I explained this clearly enough. It's an interesting modality that some people have philosophical objections to. The problem is the data is so clear that this is the most effective treatment, that to rail against it for philosophical reasons, you're just being doctrinaire. Um, the the opponents are the ones who are not evidence based. I mean, truly. But again, setting it up is a little bit difficult if you're in a private agency, because you have to have a discrete population of patients. You're going to target, you're probably going to start for the stimulant use disorder people only. You're going to have to pick your rewards, and you have to invest in it. You have to have an upfront investment of the rewards. You have to fund the fishbowl. And if you're not using a VA canteen, then what's you going to put in there? Again, are you going to use volunteer contributions? Are you just going to use are you going to use credit cards that can't be used for alcohol or drugs? I mean, vouchers that can't be used for alcohol. I mean, I don't know. It's it requires planning, but it doesn't mean it's not possible. You just have to be committed to having your administration behind it, and you have to build a program. And again, you have to not be loosey-goosey. You have to be so tight on this. And you have to have immediate results on the drug tests. That's what I learned through this. And that's why we're not doing it more large scale here, because we don't have a point of care testing system upright because of the bureaucracy of where I work. And it's unfortunate. But
Great.
I haven't
That's
seen the chat, John. I think, well, I guess I could. I can see the chat. But is there
that.
anything in there that's
Nope, that
worth
was
going?
yeah, and we're out of time, and I think it's a good place to stop. That was great,
Okay.
Dr. Miller. Thank you so much. And for those that attend all of Dr. Miller's webinars, please earmark August 14th. We'll have Dr. Miller back again. He's going to talk about advanced harm reduction strategies, which will be a very interesting discussion. So thank you again for your time, Dr. Miller, and I hope everyone has a nice afternoon. Take care.
Thanks for having me.
Thanks.